So first of all, before we start, I just want to know how many of you are managing upper GI bleed. Can you just put up your hands? 1, 2, 3, 4, 5, yeah, about 6, 7, 8, 9 here. These are all gastroenterologists, pundits are here. So I think Karthi is not managing upper GI bleed. He's just silently putting his hand out, but I think he very... So we have a lot of gastroenterologists here, surgical gastroenterologists, surgeons here. So who are all stalwarts. I don't need to teach them. But then nevertheless share some concepts of managing upper GI bleed the right way. We have still problems getting the slides on. I'm going to speak on the mid or lower GI bleed. We're going to speak only on upper GI bleed. Upper GI bleed is any bleed that happens from a pathology proximal to the ligament of Treves, which is the duodenojejunal flexion. So anything proximal to that, can get acted by acid. So it becomes acid hematine. So there is melena. If it is anything below that, you don't get melena. So that is why you can distinguish upper GI bleed clinically from other causes of bleed. If somebody is bleeding from the distal small bowel or the proximal right colon, usually it is maroon color. So you should, when taking a history, you can take a history foul-smelling, sticky, shiny type of stool, which means it's melena, which is acid hematine. Or you should ask, is it maroon colored, like kumumaputtu color? That's what we ask. Otherwise, is it fresh blood, red blood? Red blood means the bleeding is from the left colon generally. Or if there is a torrential upper GI bleed, also patients can have red blood pass through the rectum, which means it's a very dangerous situation. So I'll start with a case which is a 45-year-old male who's an advertising executive who presents to the emergency room with black stool and lightheadedness for the past 3 days. And it says stool is black, sticky, shiny, malodorous. Recent worsening of a chronic epigastric burning, which means patient has been having epigastric burning for long, and he has doubled his usual use of drugs, but no relief from the burning. And he has been a hypertensive for 8 years. He's been taking on and off non-steroidal drugs for back pain, which many patients do. They just get over the counter and start taking NSAIDs. And he's also been on aspirin for cardiac prophylaxis. He's been a smoker, smoking 2 packs a day. The diagnosis where the bleed came from, obviously. And he was also said he had an ulcer in the distant past. But, he's not sure about what happened on endoscopy or treatment. He's not sure. So, obviously, if you get this scenario, he's a patient who's at high risk for developing peptic ulcer. Like he's been a smoker, he's had past history of ulcer disease, he's on non-steroidals, he's been on aspirin. So, deadly combo. And when he came, he had a hemoglobin of 9 grams and a hematocrit of 27. And blood urea nitrogen was 45. So when there is upper GI bleed, the urea or the blood urea nitrogen goes up when compared to creatinine, which is normal, which obviously shows that there is a bleed proximal to DJ, and the small bowel, the nitrogenous blood products are absorbed and converted into ammonia, and the ammonia increases the urea synthesis. This is what happens in upper GI bleed. This is how we differentiate an upper GI bleed from a lower GI bleed. And it is not because of acute kidney injury. It is not because of AKI, because the creatinine is normal, the blood urea nitrogen or urea is up in upper GI bleed, whereas normal in the lower GI bleed. Very quick diagnostic method which can help. The other method by which you can differentiate an upper GI from lower GI bleed is, all you have to do is just put your stethoscope on the abdomen of the patient. If you hear borbering me, brisk borbering me, the bowel sounds, which means there's a lot of bleeding happening proximal to DJ, and there is a movement of the blood products through the small intestine. So this one is now the questions that we have to ask. What is the most likely cause for the black stool based on the information? You all agree it's peptic ulcer? Yes, obviously yes. What is the likely location of the bleeding site in GI tract? Proximal to the DJ, because there is melena. What will be the ideal procedure to confirm the location of bleeding site and why? Endoscopy, obviously. And differential diagnosis for the problem can be many. That's what I just wanted to show you some examples. See, when there is a patient presenting with ulcer bleed, what we do is we just get into the duodenum. You can see the slight blood clot there and ooze of blood. So we just inject epinephrine around the ulcer base and put hemoclip. So we just need a combination of injection and clipping. So we need to use a mechanical clip, and you know, it's easy to deploy. This video is at least 20 years old. Another example of a patient where there is a lot of bleed, we just give wash, thorough wash has to be done. So we have different gadgets to pump in water into the through the endoscopic channel. We just give epinephrine again. One clip was not adequate, so more clips were deployed. So these clips are not very expensive, so very quickly you can deploy any number of clips. If there is a visible vessel, then you can just seal it. We'll move to another case, which is a different scenario. This is not the typical peptic ulcer patient that we saw. This is a 48-year-old male with child C cirrhosis, massive GI bleed, and severe anemia, altered liver function, altered coagulopathy. So this was the scenario where the the large esophageal varix was bleeding. So straight away what you do is put in glue, cyanoacrylate, just inject even into the large esophageal varix. Instantaneously you can see the bleeding stopping. This is a fundal variceal bleed, which is a spurter. Just injecting glue immediately will stop the bleeding. There's another case of 45-year-old male with a binge drinking which has gone on for 1 week, which is excess alcohol consumed in a short period. So this was followed by vomiting, and the vomiting, he had vomited about 50 to 100 ml of blood. So what will be the question you'll ask here? Allergies. Yeah, you should ask the question, did you retch? Was there a retching? Ask the relative or the patient. Many times you'll get the, and you see the hemoglobin was 13.5, but many times these guys could be polycythemic. And it could be, hemoglobin could have been 16, which could have dropped to 13.5. We don't have the baseline. So we should not rub off saying, oh, this is normal. So this patient had a Mallory white tear, and if there is an ongoing bleed, you can just put clips, this is only a mucosal tear. So it is not a real deadly thing. So you can just put multiple clips and you can just, stop the bleed if he is symptomatic. Many Mallory white tears spontaneously heal. You don't need to do anything about it. We also put the collagen spray there. We've been using collagen powder through the endoscopy for the past 5 years, and we have found it very useful in many situations. And this is another 55-year-old cirrhotic, child C cirrhosis, massive bleed, alcohol intake prior, and again had a severe retching. This one had a poor half. I'm sorry about the spelling. So this one had a massive tear, and you can see even the mediastinal structures. So there's a big rent there. So what we did was, there's no way that you can clip it. So you have to suture it. What we did, we quickly deployed a fully covered metallic stent and came out, and then tackled the situation later. Patient became well and went home also well. So this is this video is not working, so I'm just stopping this. But this is a massive bleed which happened from a deployed enteral stent which had corroded through a gastroduodenal artery. So upper GI bleeding could happen because of many reasons. I showed you in a classic case of ulcer disease, another case which was because of alcoholic liver disease, but even in alcoholic liver disease could have been because of esophageal variceal bleed or fundal variceal bleed, could have been a Mallory white tear, could have been a Bohr-Haave syndrome. So all you need to know is go in and see from where he is bleeding, then you can probably do a proper job in treatment. So upper GI bleeding is any bleeding derived from a source proximal to the ligament of treats. It can be divided as a variceal or non-variceal because the management differs. And epidemiologically, 50 to 100 per 100,000 population per year is the incidence, and according to this study, and morbidity and mortality is also high with a 10 to 14% mortality. If you look at the epidemiology, the upper GI bleed is 4 times commoner than lower GI bleed, and again more males suffer from bleed than females, and the causes could be many, but the majority are non-variceal bleeding in the West when compared to the variceal bleeding. And in India, I feel that at least at this point of time, it's all 50-50. I would like to ask my colleagues, do you agree it's about 50-50, or Dr. Raja? Or you get more variceal or more non-variceal, or what is the ratio?
More variceal bleeding.
So it's like 60-40, 70-30? 60-40, how about Arun? Sir? 60-40? Still 60-40? How about the Dr. Balachandran sir and other gastroenterologists are here?
Yeah, I can put it, when I was a postgraduate, my thesis was upper GI bleed. That time, the peptic ulcer is 80% and remaining. And slowly, depending upon the geographical variation. That is, the peptic ulcer bleed is still most highest. And second comes as variceal. But if it is something like a liver unit or referral centers, probably the variceal takes upper hand. But we see, even today we see, because the PPA and things like that, the complication has come down, but even bleeding is there. The obstruction is gone, but bleeding is still there. And erosive gastritis is causing a massive bleed.
Yeah, wisely said. But still, because of the PPI used, I feel that the malarial tear is 20%, gastritis, duodenitis with erosion sometimes can massively bleed, and esophagitis, AV malformation, tumors like GIST, we have seen leiomyoma, GIST, bleeding torrentially. So we have seen all those. So, and variceal bleed, of course, gastroesophageal varices, and then lesser portal hypertensive gastropathy and isolated IGV, isolated gastric varices. We have seen isolated duodenal varices and even ileal varices bleed. So all these are possible here. So I'll just skip through the causes and go on to the clinical presentations. How do they present? Majority present only with melena, 70 to 80%. They may not have an overt hematemesis. It's only about 40 to 50% may present with hematemesis. 15 to 20% of the guys can have hematochezia, which is a brisk bleed from the upper GI tract which presents as fresh blood per rectum. And there could be others which could be slower bleeding, where the patient presents with symptoms of iron deficiency anemia. Sometimes they can also present with hypovolemic shock because of severe bleeding. So all these presentations are possible. So how do you manage? So what is the ABC? The first thing that you do is do not ask a question, is it variceal, is it not variceal, where is he bleeding from? Don't ask all those questions. You should straight away start resuscitating him. Resuscitation is the first thing that you have to do. Start, large bore cannula, start on crystalloid solution. Don't start a colloid at the beginning. So because the colloids are slow to flow, this is a golden hour like in the trauma. You need to give 2 lines crystalloid solution very quickly so that the blood pressure comes up. If somebody comes with a low BP, that means he's in real shock or hypertensive shock. So first give crystalloids, bring up the fluid, bring up the blood pressure. Then, you can use whatever you want. Like if somebody has a hemoglobin of less than 8, then you can use a packed cell. Somebody has, low platelet count, you can give platelet transfusion. If somebody has got a coagulation abnormality, you can give fresh frozen plasma. So you can just transfuse whatever you want later on. But first, resuscitation, you have to, as you're resuscitating the patient, keep monitoring, taking history from the patient, from the relatives, and also examining the patient. All can go simultaneously because you'll have to take care of the airway, breathing, circulation, everything has to be taken care, That's important. So brief history, as soon as possible, you should take. So you should be able to decide, in a country like India, is it a variceal or non-variceal bleed, and then immediately start acting. And localization, early endoscopy and a nasogastric tube can be a great help. Just pass a nasogastric tube and aspirate. If there's, even right now, I just came 15 minutes late because we have an emergency bleeder and I just got admitted, and we put in the right tube and then we aspirated 400 ml of coffee grounds liquid, which means I'm not really bothered. I instructed the nurse, if it becomes fresh blood anytime, hourly aspirate, 4th hourly lavage, if it becomes fresh blood, immediately alert the team and we'll be there to do emergency endoscopic management. Otherwise, we can just stabilize the patient, take up the patient tomorrow morning because patient otherwise is stable. So, localization, early endoscopy and nasogastric tube can be great help, and therapy, endoscopic, pharmacotherapy and surgery. So, I'll dwell upon a few minutes on pharmacotherapy, then of course on surgery, just for completion's sake. So the nasogastric lavage I spoke about is very important. So management is pharmacologic management. You can use octreotide, terlipressin, octreotide, and even somatostatin can be used. So in the periphery, when somebody rings up to say that we are transporting a patient with upper GI bleed, so what I would request them is, one, send a nurse. If there is a rice tube, please keep lavaging or aspirating at least. And then if you have access to using octreotide, give at least 100 microgram of octreotide as a subcutaneous injection. If not, start on 250 microgram of somatostatin IV bolus, followed by a continuous infusion of somatostatin 3 milligram in 24 hours, which is 250 microgram per hour. Infusion of somatostatin. If you don't have access to somatostatin, at least give octreotide. And if you're using terlipressin, if it is an elderly patient, a cardiac patient, beware. Sometimes there may be coronary vasospasm, which is possible, even though the previous molecules used to produce that. Terlipressin is much safer, but still one has to be more careful. Just a 1 milligram injection of terlipressin before transportation from the periphery to a tertiary referral center to the intensive care or an active endoscopy management unit will always help in safeguarding the patient's stability by the time the patient reaches the referral center. And of course, the tips and the decompressive devascularizing surgeries are there, and some of the methodologies endoscopically I showed you. For want of time, I'm not going to dwell on that. So the first thing any patient with GI bleed that I would manage with is use a proton pump inhibitor, because there will be a lot of studies which showed an intravenous proton pump inhibitor can reduce the morbidity and also reduce the mortality. And then the patient is taken up for endoscopic management. One need not rush straight away from the emergency room ER to endoscopy room, because you need to stabilize the patient. Because if there's a lot of blood accumulated in the stomach, if you pass the endoscope one wrench and the whole thing comes up, and patient, unless you protect the airway with the cuffed endotracheal tube, the patient can aspirate and collapse and die there. So I wouldn't immediately jump to doing endoscopy on this patient. I would just first stabilize the patient and then probably take up. So what to transfuse? I told you, transfusion of RBCs, the packed cells, if the hemoglobin is 7. Patient with pre-existing coronary vascular disease and hemodynamically stable condition, you can transfuse even at 8 gram per deciliter. So pharmacotherapy, rabiprazole, panto, esomeprazole, omeprazole, IV are all available. But what is the choice? See, if you have I've seen many units using pantoprazole IV 8th hourly or 6th hourly, which is not the right way to go, because pantoprazole has got a very short half-life. You have to use rabiprazole if you're using bolus doses on a 6th hourly basis. Rabiprazole will keep the pH at a neutral pH of at least 6 to 7. So if you're giving pantoprazole, you'll have to give 80 milligrams of bolus of pantoprazole IV, followed by an infusion of pantoprazole 24 hours round the clock. So at least 200 milligrams of pantoprazole has to be given in an infusion form. So if you don't have the time or the patience to start an infusion and then continue with the syringe pump, all you can do is just give rabiprazole, 20 milligram IV as a bolus, and then follow it up 6th hourly. So bleeding from an ulcer, how does the PPI work? Because the bleeding from an ulcer, there is the clot starts to form, and there is a fibrin which is formed from the fibrinogen, and the fibrin plug is formed. But what happens is, if the gastric pH is below 4, acidic pH, then the pepsinogen gets activated to pepsin, and the pepsin can go and dissolve the fibrin clot. And then, so the fibrin clot is gone, and then again the ulcer starts bleeding. So this is what happens. So whereas on the other hand, if you use a PPI, if you have increased the gastric pH to 6 or 7, then the pepsin no more is formed from pepsinogen, which is a proenzyme, and the pepsinogen is not cleaved to pepsin, and so it cannot go and disturb the fibrin clot, so the clot stabilizes. So this is how the proton pump inhibitors act. And the international consensus recommendation from which has been published in Annals of Internal Medicine 2010 says that IV PPIs in all patients with high-risk lesions post-endoscopy therapy and pre-endoscopy therapy. Pre-endoscopically, it downstages the lesion, and post-endotherapy also you continue IV PPI. Many of the units across the globe would treat for 5 days. You at least treat for 2 days and then switch them to oral PPIs when they get discharged. So the Scottish Intercollegiate Guidelines Network recommends high-dose IV PPIs in all patients with major peptic ulcer bleeding or even non-bleeding visible vessels after endoscopic bleeding control. Say a visible vessel, you just always clip it. So GI bleeding in cardiac patients could be a big risk, especially the elderly cardiac patients, very vulnerable also. Multiple risk factors, advanced age, high burden of comorbidity, and the polypharmacy of using anticoagulants, ASA, clopidogrel, and other antiplatelet drugs, and pre-existing mucosal defects all make them a big risk. So in cardiogastroenterology, so how to minimize the risk? So I don't know whether you can see this. Yeah, it is at least readable. So you can use the lowest dose of ASA, and people have shown, if Dr. Bhaskar would agree, 75 milligram of aspirin is safer in this patients. No need to use a 150 milligram of higher doses. And if there is H. pylori, remember to eradicate it. If at the time of bleed, we won't have the time to look for H. pylori. So after the bleeding episode, as everything is controlled and you put the patient on PPI, ensure call back the patient after 4 weeks for repeat endoscopy, ensure ulcer healing, and then at that point of time, you can check for H. pylori, eradicate H. pylori. If you don't do that, patient comes back with bleed. We had a hemophilia boy, twice he came with bleed, and then at no point we checked for H. pylori, and he came with the third time bleed, and then at that time we checked for H. pylori. It was positive. After eradication, now it's about a year, he never came back with another episode of bleed. So PPI gastroprotection is very important, and I think all gastro colleagues would agree that the cardiologists would be using more PPIs than all of us together, because they are the people who use a lot of drugs like aspirin and clopidogrel. I'm sure they use that, and the Cogent trial showed that PPIs led to a 66% reduction in upper GI bleed among patients with dual antiplatelet drugs, and the Oberon trial also showed a recurrence and occurrence of PUD among a low dose aspirin and PPI. So which means combining ASA or clopidogrel antiplatelet drugs with PPI is justified, because it lowers the occurrence of new ulcer, also reduces the bleed from these ulcers. So, and the rabiprazole, the trial was done in Asian Institute and published in 2005, which showed that it is rapidly acting. IV rabiprazole only takes 12 minutes to take the pH up to 6. So it seems to be more efficacious. If you see anything below the dotted line shows high acidity, that is pH 4, and anything above this line, and above the red line means it is a neutral pH. So rabiprazole could quickly elevate it, so in a bolus dose, and it prevents GI bleed and ensures the ulcer healing. So endoscopic methods of treatment I just showed you. For want of time, I'll just skip through. So there are a lot of devices like hemospray, which is a coagulation spray, the hemoseal spray which we use, because hemospray is from Cook, which is not available in India. That's why I just started using collagen powder, and been found to be very useful, because collagen starts acting in any mucosal bleeding lesion or ulceration or erosion. It comes into play by day 5 to day 7. Here, by introducing collagen on the lesion, on the base of ulcer, the healing immediately starts because the collagen matrix forms, and then the epithelial cell, migration can happen, and platelets can go and adhere and form a stable thrombus over the collagen. And it also combines with a von Willebrand factor, which just comes up whenever there's a mucosal break. Beautiful studies have been done, and new publications are there on that too. So, surgical management, we have a lot of surgeons here. Unless there is severe life-threatening hemorrhage, we don't call the surgeon today. Mostly we can manage with the medical therapy or endoscopic hemostasis. So I'm just skipping all this forest classification. We can just, looking at the ulcer, we can predict will it rebleed or not, and then make strategies accordingly. And I told you, H. pylori, please treat. If there is a non-steroidal drug which the patient is taking, please stop it. And if the patient is on dual antiplatelet therapy, please stop the clopidogrel and other groups, and then use only aspirin. And again, you can use low-dose aspirin. Aspirin can be started within 24 to 48 hours after control of bleed. So you can start immediately. And of course, anticoagulants, use short-acting anticoagulants, because rapidly you can reverse, at least in the initial phase of 5 to 7 days. If the cardiac condition warrants an anticoagulant which cannot be stopped, then, like for example, drug-eluting stents and all those things, cardiologists are very sensitive. They don't want to stop the anticoagulation. So use short-acting anticoagulants. And this is the algorithm. I'm going to close with this. So an acute upper GI bleeding. So if there is an ulcer, give IV PPI and preferably bolus IV rabiprazole, because it quickly elevates the pH, and then you can switch to oral PPI. And of course you can treat with endoscopy if there is a visible vessel or adherent clot. We remove the clot and give the treatment. And for esophageal varices, control the bleed. Even a Sengstaken Blakemore tube can stop the bleed of esophageal varices or the gastric varices. Then you can, after 12 hours of stabilization, you can take up the patient. If there are esophageal varices, you can band them. If you see a spurter, you can just give glue. If there is a spurter in a fundal varix, you can we don't use bands because they can slip and produce torrential bleed. So we just have to block it with cyanoacrylate. The Americans don't have cyanoacrylate. They're the underprivileged guys when compared to us. We've been using cyanoacrylate from, at least to my knowledge, right from 1987 I've been using. This is my 30th year of gastroenterology. We've been using cyanoacrylate, which we got from Germany. The Americans still don't have cyanoacrylate. So they are at a big loss. So Mallory white tear, of course, majority don't require treatment. If on endoscopy you can see the bleed, you can just clip it as we showed. So that's about it. That is the last slide, and thank you very much for this very patient listening. So in the past few minutes, I've tried to tell you what is an upper GI bleed, how to differentiate it from a mid GI or a lower GI bleed. And when you have a patient with upper GI bleed, resuscitation comes first. So ask questions as you're resuscitating. So, and then do not jump to endoscopy straight from ER. You just stabilize the patient, put in a ice tube, aspirate, lavage, stabilize, then take up to endoscopy. Then the success rates of endoscopy is also high. You prevent a patient from aspirating and dying. And the IV proton pump inhibitors have come in a big way to help us to control the bleed, reduce the morbidity and the mortality. And you have to separate out a variceal from a non-variceal bleed and then tackle accordingly using endoscopic methodologies and the surgery. And also we have the radiographic embolization. They're all limited when you cannot pharmacologically or endoscopically manage. Then you go for CT visceral angiography, demonstrate the bleed, and then go for an embolization. Then the patient can be saved. If all else fails, we always have our surgical colleagues to run, to surrender. They're there to help us all the time. So thank you very much to Kenila for giving me this opportunity. I think Dr. Balshanur has a question before I close.
Excellent.
Or a comment.
I have only one this thing. I mean, surgeons are
even if you have done the injection or whatever clip, there is a chance of rebleed. So in our hospital, every case to caution us. As a old man, I have done. But the surgical team, duty team period, anytime rebleed, you may have to go in and do underrunning of the vessel or taking them to gastric. That's the only caution is old age atherosclerosis. And then number 2 is about the sensitive tube, black one. Of course, we are not using nowadays. What's your experience? Are you still using that?
Yeah, we still use at times, not regularly. Say, for example, this bleeder here in our intensive care is a decompensated cirrhosis. Yesterday he had binge drinking of alcohol. We had done band ligation earlier, and then now he came with the GIP. So we have kept sextated tube next to the patient. We are not using it at this point of time, but we have it as on an emergency protocol. We have it there. So we don't use generally.
About this variceal banding versus variceal injection. Injection is totally out. Even in emergency, you do only the banding. That is a little change.
Yeah, right, absolutely. See, in the 80s when we started doing, we didn't have the bands. We had to do sclerotherapy. So we used to use ethoxysclerol, or we used to use polydocanol. And absolute alcohol used to be really scary because producing huge inflammation and ulceration, necrosis and deaths. So, that was tried by Shivsari's group, and then nobody ventured to do that. So STD, sodium tetradecyl sulfate, or the polydocanol used to be the favorite agents. We had no other choice. But if there is a large varix in the esophagus bleeding torrentially, these polydocanols or STDs, even if you will inject 2 cc or 3 cc at each site, you go paravaricial, produce, and then intravaricial, nothing works. Immediately give half a cc of cyanoacrylate, just instantaneously stops. That's what I showed you. But in the 90s, 94, I got this single band device from Singapore. So every band had to be loaded on the endoscope, then we had to go in, we had to put in an open tube, and then we had to. And it was Saeed, who's a Pakistani guy settled in the United States, gastroenterologist. He was the one who said, this is so cumbersome. Can we just put 6 bands or 5 bands together, and then can we use a thread? And then this one he did. So he just, tied them to the thread and loaded on a barrel, and it was attached to the tip, and the thread was taken up through the endoscopic working channel and then attached to a handle unit. So once you rotate, one band will deploy, rotate again, suck, rotate, band deploy. So very quickly we can use this. So why do we need to use sclerosant today? Because sclerosant again is a problem, because I have been using sclerosants for 7 years. You just inject and take it out, it will spurt again. So because if the coagulation defects or some problem, prothrombin time is slightly high, platelet count is slightly low, or with the portal hypertension, high portal pressures, you can inject, take it out, it will rebleed. So it used to be nightmarish. I've in fact lost one patient like that, continued to bleed, never could stop in the 1990. So grateful today, it's so easy, even for any resident in the gastroenterology department, he can go and deploy the bands. So that is why we use only variceal blanks. We don't use, these, injection scleral.
Last 2 questions are about this Dulophois lesion. You put a clip, Dulophois.
Yes.
Just stops bleeding.
Absolutely. Yeah. Just the clipping is the best methodology for Dulophoid. Otherwise, what you can do is you can use an endoloop. I've done endolooping also for Dulophoid. Just load up the endoloop barrel cylinder, because the cylinder also is very helpful. You can just go close to the lesion, just suck it, and then apply the loop. Perfectly it works.
The last question is prophylaxis of bleeding. You have an endoscopy, no bleed, but you have a varices. Propranolol versus banding. What do you prefer?
You can start with propranolol, sir, but I would like to ban if the varices are big. If the varices are just grade 1 or grade 2 in a patient who has never bled, I don't think we need to worry about it. So for those youngsters, let us not talk about grading. Now we say small varices, medium varices, large varices. If somebody has medium or medium to large, I would probably ban them first and call them on a 4-weekly basis for reducing the size of the varices so that we can prevent bleeds. Otherwise, they can torrentially bleed in the middle of the night, especially people from a long distance who to reach the tertiary care center, people with some rare blood groups, previous history of bleed. I mean, you said a naive case, which
is beautifully given in variant law. 30% of patients die before they reach the hospital.
Yeah, absolutely, absolutely. So we should electively ban them if because sclerotherapy, elective sclerotherapy was not recommended, because you used to inject and it used to bleed. So for that, the small chance, 10% chance of inducing a bleed in a patient who has never bled in his lifetime. I've had one patient like that, but we controlled again. So in the early 90s, this was a school teacher who was so upset with me. I've never had a bleed. You created a bleed, and then you had to treat actively. I had to be admitted for 48 hours. I apologized to him. I said, I'm really sorry. But so now there is no
Sarin group has done the prophylactic varicose banding. Myself and LDK we done before 10 years, comparing 25 patients, one group with propranolol, other group with only with varicose banding.
And what was your study?
Yeah, varicose banding is
superior to propranolol, because propranolol has its own side effects and the dose
osmotic and things like that.
And the joke, of the dose of propranolol, no one knew, because they said next door to the gastroenterology unit, next door was Librec's office, and this gastroenterologist went in and asked, how much of propranolol do you use in GI bleed? Said, oh, it's simple, just reduce the heart rate by 10%. So 25%, what is it? 25% or 10? 25%, I think. You have to reduce the heart rate by 25%. And this was what was followed by all gastroenterologists without any scientific validation also. That is a joke that goes on, how this 25% reduction in the resting heart rate was decided just by asking a question to Librec. So propranolol doesn't act in all patients. So I think band ligation in moderate to large varices. Small varices, propranolol. Again, now the warning is, if somebody presents with ascites, already decompensated, we don't use propranolol anymore, because it can produce a vascular compromise and can worsen the whole circulatory system.
Thank you, sir. Thank you for the talk. Thank you.